All right. Also, real big thing here. I'm going to start with the case now. If any of you guys, I really want it to try to be interactive. If you guys want to answer and you want to come in and speak and be involved in the conversation, just raise your hand. We'll kind of bring you up. If not, you guys can just put any kind of questions or answers or anything that you guys want to talk about into that live stage text, and we'll kind of keep an eye on that. All right. So let's go through a case. All right. So this is a pretty cool one. So let's say that it's your first night, okay, on call. Let's say you are asked by a resident to evaluate a patient in the emergency department, okay? You go and see the patient. It's an 85-year-old female. She's got a history of Alzheimer's, dementia, and hypertension, okay? So that's her pertinent past medical history. She came to the ED via ambulance from a nursing home, and her primary chief complaint is that the nursing home noticed that she was kind of becoming more confused and having this decreasing mental status. On arrival, the blood pressure is noted to be 80 systolic over 40 diastolic. And the pertinent medications that they bring note of is that she's taking Aricept, which is also donepezil. She's taking hydrochlorothiazide and metoprolol. So that's kind of our basic HPI at this point in time. Any of you guys have any questions, any other additional questions that you guys would like to ask about just the basic part of her HPI real quick?
Thank you, Rob, for the little overview there.
Yeah, I like it. Beautiful. That's awesome. Very good kind of summarization there. People say that case studies are beyond them and are afraid of taking part because they think they can't or shouldn't. Listen, guys, if you guys are, there's going to be no judgment whatsoever. It doesn't matter what kind of answer you give. If you don't know, that's okay. I think this is a great opportunity to learn. It should just be a learning opportunity. Do not be afraid to provide any answers. No one's going to judge you at all.
Oh, Aricept?
Yeah, Aricept is also known as donepezil, which is basically it's for Alzheimer's, and they're also taking metoprolol and hydrochlorothiazide, and that's for their hypertension. Okay, all right. So right off the bat, we can already kind of start saying, okay, we have a basic HPI. The basic things I want to know about the HPI: past medical history, chief complaint. So we already know their past medical history is Alzheimer's, dementia, hypertension. Chief complaint is a decreased mental status, confused more than usual, and came from a nursing home. So let's go ahead and quick say, okay, that's what we got at this point in time. We still don't have a lot to go off of other than the fact that her blood pressure is really low. Systolic is way less than 100 millimeters of mercury. Could it be that she took too much of her? Oh, someone already put that in there.
Yeah, Rob did.
Good. That's a good question. Maybe she took too much of metoprolol. Maybe, I don't know, maybe the nursing home gave a little bit extra metoprolol or the hydrochlorothiazide. That's a good thing to be thinking about. Absolutely. That's a potential differential to be on your eye. That's a potential differential. So I think that's a good thought there. Did she take too much of her hypertension meds? That's a good thought. All right, let's say, because we don't have a ton to go off of at this point in time, I'd say let's go ahead and do our physical exam. Any queries on doing a physical exam at this point in time? No?
Which physical exam would you want to do first?
So yeah, let's do a nice quick focused physical exam. Let's start off with doing just a cardiopulmonary exam. So if we start off on her physical exam, here's what's going on. Patient's lying in the bed, right? She's not arousable to auditory stimuli. She's not arousable to natural kind of like touch, like tactile stimuli, but she's very difficult to arouse with some painful stimuli. So you're having to apply some sternal rubbing to really kind of get her to arouse and awake and try to answer some of your questions. So that's the first thing for her mental status, I'd tell you. Her pulse, if we look at her vitals, her pulse is 120 beats per minute, so that's her heart rate. We recheck the blood pressure, it's still 80/40. Her respiratory rate is 18, and her temp is 101 degrees Fahrenheit. Okay, so definitely some concerning signs there on her vitals and as well as her basic mental status exam. You listen to her heart and you listen to her lungs. She's clear to auscultation bilaterally, no wheezings, no rhonchi, no rales. She's got a regular respiratory rate, normal S1, S2, no gallops, no rubs, no murmurs. You start to go and palpate her abdomen. As you palpate her abdomen, she's non-tender to palpation in the upper right, upper left. But as you start getting towards like the suprapubic region, she's got some pain there. So she's hurting when you push on that suprapubic region of her lower abdomen. Okay? The rest of her exam, though, her pulses are +2, distal pedal pulses are +2. She's got no edema. There's no skin lesions or rashes. Her neuro exam is normal. Her HENT exam is normal as well. You're a little concerned, right? So you go ahead and put a Foley in. When you put a Foley in, you notice something very interesting. That coming out of the Foley, you notice some dark urine and some pyuria. All right? That's our physical exam at this point. Anybody have any questions, any concerns, any things that they want to say at this point?
I'd be pretty worried about infection, either pyelonephritis causing sepsis.
Very well could be.
But
This the suprapubic pain with that kind of pus there, it could very well still be a pyelo. Usually the pyelo would again be a little bit more towards that flank pain, but that doesn't mean that it couldn't still potentially be a pyelo. The fact that she has a fever and she has some pyuria, she's got some suprapubic pain. It could be cystitis that may be extending retrogradely up into like the actual kidneys. But no, Josh, she does not have any flank or CVA tenderness present. All right, but I think a couple people have already had the right idea thinking, okay, is this UTI? Rob even asked, is this rhabdo? Could be, very well could be. We don't know. We don't have any documentation if she was kind of having any, she was like, if she fell and she was found down in the nursing home for a long period of time, there was no documentation of that. So I don't think so. It seems like she just may have really dark urine from concentration. Maybe she's a little dehydrated. That's maybe a thought there. But I think you guys are having some good ideas. Anybody have any questions? The Yermans, you said something?
what's her CPK?
So we'll get to that. We'll get to her labs here in just a second. We're still on kind of our objective assessment.
Gotcha.
So everybody good with kind of our objective assessment here? Josh asked about volume status. Okay, let's say that you want to assess volume status really quick. How would you quickly assess volume status on a patient?
Skin turgor?
You can check skin turgor. Let's say that it's a little. Let's say that she has some kind of wrinkly skin. She definitely has some skin turgor present. What else? I like it. I'm a big fan of ultrasound, so I would take a look at her vena cava. I would also look at her mucous membranes. Does she look dry? If her mucous membranes look really pale, that's also kind of an indication. You can check cap refill if that's delayed. But I'm a big fan of checking the IVC. Again, we're getting to more of the later studies that we can do, but this is a good quick thing that you can do as a bedside ultrasound. Check the IVC, and you're checking for collapsibility. We don't want to get too far down that chain, but yeah, IVC ultrasound to look to see if it's collapsible or if it's changing with breathing can also be an indication if they're volume down or normal volume. So I like it. All right, so let's quickly recap. Patient has a past medical history of hypertension, Alzheimer's, taking Aricept for the Alzheimer's, taking hydrochlorothiazide, and taking the metoprolol for blood pressure control. She comes in with a decreased mental status. Her physical exam shows that she's definitely difficult to arouse, so probably in some form like obtunded, maybe stuporous. She's tachycardic, she's hypotensive, and she's febrile, and she's got pain in the lower abdomen, particularly that suprapubic region. And we got our ninja nerd, Kristen, here asking if there was any GI complications or abdominal surgeries. When we go through her past medical history and surgical history, we didn't have any note of any surgeries present as well. That's a great question. All right, so let's move on. So we have a pretty good idea about her physical exam. Really, really quickly, I want someone to at least say there's a particular type of criteria that I'm a little bit concerned with. It's particularly pertaining to you take into consideration their temperature. You take into consideration, yep, someone already said it. Josh hit it. Boom. SIRS. I'm definitely thinking about SIRS right now.
Rapunzel's going for sofa?
So Sofa, definitely, she's ahead of the game, but eventually we're probably going to get to that point with this patient. Absolutely. So sequential kind of organ function assessment for especially in septic shock, we may be getting there. But SIRS is the first thing I can already note just based on this patient's vitals. So I can already notice that she's febrile, and she's hypotensive, and she's tachycardic. Those are right away indications for someone to be a SIRS criteria. Now, what is the difference between SIRS and sepsis? How do I need to prove that this person is actually septic? So bacteremia, yeah, I need a source of infection. I need a source of infection. A white blood cell count is also added into the SIRS criteria, but I definitely need a specific site of infection. I need some proof of infection. So that would be either getting a chest x-ray, looking for pneumonia. I would either get some blood cultures looking for bacteremia, or I kind of already have an idea where this infectious source is coming from. It seems like UTI, right? A couple of people already said that. So I could already kind of start my process off here and get a UA. So right now, I'm a little nervous that this person may have sepsis. Right now, they're meeting SIRS criteria. So I need to go ahead and find an infectious source. Can anybody tell me a couple labs that maybe I'll fire off, a couple labs in imaging that I'll fire off really quick to kind of be very thorough, especially in a patient that I think may have sepsis? We already mentioned a couple of them. So someone said UA, good. Blood cultures. How many blood cultures?
2 blood cultures.
2 blood cultures, good. UA, okay, I like it. So you can get a BNP. I would probably extend it to a CMP. I want to know what their liver's doing as well, because sometimes whenever people become septic and especially shocky, that can really affect their liver. So I'd extend that from a BNP particularly to a CMP. So we got a CMP, we got a UA, we got blood cultures. Someone asked, I'm a bit lost, have we ruled out anaphylactic shock? That's a good question. They haven't, again, when I listened to their lungs, when I did kind of a good lung exam, I didn't hear any wheezing, I didn't hear any rhonchi, rales, and I didn't appreciate any stridor present on her exam. But that's a good question. Very good question. I didn't also, again, there was no skin lesions as well, no rashes or hives or anything that could point that out as well. Good question. And no angioedema, no enlargement of the tongue or anything like that. All right, so we got a couple of them. CMP, we got a UA, we got blood cultures. What else? Anybody know what else? You get a CBC, right? Oh, chest x-ray, good. I get a CBC. Okay, you can do a CT of the abdomen, absolutely. That's fine. I would probably make that a little bit later. I probably wouldn't get right into a CT of the abdomen since I kind of have an idea of where the infectious source is. But if I got a UA and they came back negative, then maybe I'd go and I'd do a CT abdomen. Urine culture, you can. I'd just be careful with urine cultures, especially if they had a Foley in for a little bit. Sometimes, you can get in a little bit of trouble with those. But all right, so I would stick with the UA. You can send urine cultures Generally, you try not to send urine cultures if someone has a Foley in, but I go with the UA first. All right. So I think a lot of people have hit it. I'd start off with a CBC. I'd do a CMP. Okay. I would do a UA. I'd do some blood cultures. I definitely would do a chest x-ray. And I would also throw out a lactate. So people are throwing out CRP, ProCal. Those are good. CRP is kind of a general marker of badness and inflammation. ProCal, there is a lot of people out there who believe in ProCals. I think they're great whenever you're trying to trend antibiotic kind of effectiveness, and if you want to discontinue an antibiotic, particularly in someone who has bacterial pneumonia. But no, that's a good one to think about. Someone has a question. Person has requested to speak, so let me go here.
Got him.
You got him?
Yep.
Why do we calculate lactate? That's a good question. So lactate is an indication of particularly, there's a lot of different types of lactate, right? So lactic acidosis, if you really want to think about it like that. So lactic acidosis, there's two types, type A and type B. Right now, I'm worried about type A. So with type A lactic acidosis, we're thinking about a hypoperfusion, right? Whether this be due to the person having anemia, whether this person has low oxygen carrying capacity because their lungs are jacked up, their red blood cells are low, or they have a clot that's occluding blood flow to an organ, or they're in shock and they're not able to perfuse those organs well. So when that happens, you don't get oxygen to the tissues. What happens is, your glycolysis pathway, you take glucose into pyruvate. Pyruvate eventually gets converted into acetyl-CoA. If you don't have that oxygen, though, it starts building up into lactic acid. And so that can be an indication of potentially hypoperfusion. All right, so Panos had a question.
Hello, can we take the exams about PT or PTT?
You can, absolutely. That's a
Yes.
good one. Coags are a good thing, especially if you're worried about the person having DIC. So sepsis can lead to DIC, so that's not a bad thought to throw in some coags. I like it. Especially if you're even trying to, again, determine how severe the patient is. And that's what we could kind of get into with like the SOFA score and stuff. Okay, great question, Panos.
Okay, and one more. We check and creatinine about the urine.
I'm sorry, say again.
We check creatinine.
Creatinine, albumin in the urine, is that what you said?
Okay.
I'm so sorry. I couldn't make out what you said. I apologize. Can you write in the live
Okay.
text?
What?
Can you write that in the live text, the live stage text?
Okay.
That's what I thought he said. Okay. Yeah, I thought so. You could do that. I'm not too. I wouldn't probably waste my time checking the creatinine in the urine, because I'm going to get my serum creatinine from, which is kind of a little bit more, particularly for me, if someone is septic. I want to know a little bit more of their serum creatinine than their urine creatinine. But that's a great question. All right, so to pretty much mark it off here, I think a good starting point would just be a CBC, a CMP, a UA, some blood cultures, a chest x-ray, a lactate. If you want to even go further and check an EKG, definitely can. You should always kind of check an EKG in patients who are shocky. It's always a good idea. So let's start with there. And then again, if you want to add on further tests, you definitely can. This is just what I start off with based on this patient here that I had, okay? So let's say that you do this, right? You order those labs, it comes back. And really the big thing that pops out here is they have a beefy white cell count, all right? A white cell count of 22. And you check their band cells and they got a bandemia. They got a bandemia where they have band cells greater than 10%, meaning that they have a left shift as well. You check their UA, and their UA shows positive leukocyte esterase, positive nitrites, and they have greater than 100 white cells in their urine. I think you guys already kind of know. I think people were already poking at this right from the beginning. What are you guys thinking at this point in time? Well, here, really quick before I even get into that, let's keep going through the other stuff. CMP was relatively unremarkable. Their BU and creatinine wasn't anything really off the charts. So nothing really popped off for the CMP. The lactate, let's say that it was a teensy bit elevated. I think it was like 2.2, but nothing scary. And their chest x-ray was normal, and their EKG showed some old bundle branch block, but nothing special there. I think it was a right bundle branch block, but they were sinus tachy.
Did the blood cultures come back?
Blood cultures came back, and the person did have some bacteremia.
Which species?
So that's a good question. So let's say that this is a gram-negative rods.
E. coli?
Could be. Yeah, could very well be E. coli. So at this point in time, I definitely am a little nervous, right? Thinking that this person had a UTI that caused sepsis, right? Potentially lead to that bacteremia there. So at this point in time, what can I say? All right, let's go back a little bit to that definitions. SIRS criteria was met based upon the person's, right now we can actually base their SIRS criteria. They had an elevated white count, they had a fever, right? They were hypotensive. We can also say that they had an infected source. So we have found a source of infection based on their UA and positive blood cultures. But go back a little bit more, their blood pressure is very low, and they're not perfusing particularly maybe some organs very well. Let's say that in that situation, what are you maybe a little bit nervous about them potentially developing? Septic shock, yeah. I'm definitely worried about them going into septic shock. So at this point in time, I'm definitely worried about sepsis. They definitely have sepsis. There's no doubt about that. So what I'm going to do is I'm going to start treating them with all the things that they need for sepsis. And Kristen's already hitting it right off the bat. I'm going to hit them first and foremost, killing that infectious source off. What is the infectious source? It's the UTI. What would be a good antibiotic that I would give IV that would hit some gram-negative rods? Broad spectrum, yeah, you could definitely go broad right away. I'm going to lead more towards Josh. I like Josh's answer. Cipro, that's a good one. Definitely a good one. I preferably would start off with Rocephin. Rocephin's going to be a pretty good one that has pretty broad coverage. It's the 3rd generation cephalosporin. So I'd start off with IV Rocephin. And then let's say that I did like order some, other cultures later, and I saw that there was some, it came back and it showed Pseudomonas. Then I would add on maybe if I wanted to. But if I was really, really concerned, because again, if it's gram-negative, it could be a lot of things. If I really wanted to, I could add Rocephin on. And if I was still a little bit concerned, I could even add on something that's going to cover my Pseudomonas. So if I wanted to, I could throw in some Zosyn, which is piperacillin tazobactam. I could throw in some ceftazidime. I could even throw in an aminoglycoside if I wanted to. And if those cultures came back later and they only showed E. coli, then I would just get rid of those and keep the Rocephin. But yeah, I think it's a good idea. Since there was no gram positives, I would just start off with Rocephin and add on maybe Zosyn. That'd probably be my go-to at that point in time. I think that would cover most of your bacteria. We'll talk about that. I think we'll get to that eventually. So the next thing is, okay, we covered the infection. We've got our broad coverage. I would start off with Rocephin. If I was a little bit nervous, though, I may even add on Zosyn. Okay, I think that's a good start. Next thing is Josh hit it. Fluid resuscitation. So I gotta blast this lady with fluids. Okay, so I'm gonna start off with a 30 cc's per kg. Okay, and I'm gonna hit her with a lot of fluids. Okay, at least 2 liters of fluid, within the next like hour at least. I'm gonna give her as much fluids as I can and see if that brings her blood pressure up. So let's say that you volume resuscitate her, right? You start your intravenous antibiotics. You give her a ton of fluids. Let's say that you've given her like 2 liters of fluids in an hour. Okay, maybe even going towards 3 liters. And you come back a couple hours later to check on her, and her blood pressure is still low. Still low after you've given her some decent amount of fluids. What do you do now? That's a good question. Urine output. Let's say her urine output's low. Say her urine output's low. I like that question. That's a very good question.
What's our EGFR?
So at GFR, again, whenever somebody has an acute kidney injury, which is more likely in the advent of sepsis, GFRs aren't great. If I gave you her baseline GFR, maybe that would be helpful because that may tell you if she has some underlying CKD. But it's not great in the setting of AKI. So I would be more likely to say, okay, what's her creatinine and what's her BUN at this point in time, just to see if her AKI is getting any worse. Now, remember, I told you before that she didn't really have any kind of significant increase in the BUN and creatinine, nothing that was kind of like alarming. But let's say that we wanted to do that in the meantime. I'm not too worried about that right now. I just know I gave her a bunch of fluids. She's still hypotensive. She's not making much urine. I could send off a BMP in the meantime to go and check the serum creatinine and the BUN. But what would I do next? Again, a couple people have said it, but I would try again one more thing before I go to those drugs. You can check a lactate, yeah, sure. But again, what am I going to do in the now? I gave him fluids, decent amount, maybe 2-3 liters. Urine output's low, still hypotensive. Yep, exactly. I give another probably liter of fluids. I give more fluids. I wouldn't jump right to the pressors right away. I think that it's a good idea if you need to, but the fact that her urine output's low, and the fact that, she's still hypotensive, and I very well could, Josh, I could easily check to see if is she truly volume responsive? Would she respond to more fluids? I could definitely check her IVC. I could absolutely do that. Yep. So let's say I gave her another round of fluids and the blood pressure was still low. Now what do I do?
Pressors.
Yeah. So I give her some pressors. What pressor is the number one first line pressor in someone with septic shock? Because now this person's definitely septic shock. Yeah, norepinephrine. Yep. So I'd start with norepinephrine, also known as Levophed, and I would titrate that until I approach a MAP. So this is a good question, I think, to ask. What am I titrating the pressor to, or what parameter am I using to determine if the drug is actually working or not? I was kind of doing the same thing. Yeah, Rapunzel. So I should have mentioned this before. Fluids. When I'm giving fluids, I'm using it to not only determine their urine output, that's a great, but their MAP. Dan said it. Yeah. So I should have said that before with the fluids, is checking their MAP. Is their MAP increasing? And particularly, all we really need to perfuse organs well enough is a MAP greater than 65. So if my MAP is greater than 65 with only a little bit of levo, I'm happy. But if I gave her levo and her MAP is still low after I fluid resuscitate her, let's say I maxed her out on levo, or I'm getting close to maxing her out on levo, what's another drug I can add? And this is where there's various debates. You're not wrong. It obviously, there's a lot of different factors that come into this, but just curious to see what you guys think. I hate dopamine. Dopamine is the devil's drug. I never use dopamine. I think some people may be a little bit more comfortable with dopamine. I hate it. just because it's not titratable whatsoever. It's a terrible drug. I know I can see if you guys can tell I don't like that drug. I think Rapunzel's hit a good one. I like Epi. I'll add Epi on sometimes. And I'll also add Neo. Neo is a very strong. It's actually more concentrated than Levo. It's going to be really clamping down those vessels. So if I need to, I'll probably reach for Neo, phenylephrine. So I do like phenylephrine. Epi, if I really need to increase their cardiac output enough, especially if maybe they have an underlying concomitant cardiogenic shock. But usually whenever someone has a cardiogenic shock, I'm using what Alan QT already said, like milrinone, which is a phosphodiesterase inhibitor, or dobutamine, to really increase their cardiac output. But I think the big thing here is right what everybody said: fluid. Approach MAP greater than 65, not working. Levofed, add on. I like Neo. Epi is okay, especially if they're really bradycardic. Phenylephrine or Neo is good, especially if they're really tachycardic. Okay. Sometimes people even add on vasopressin as well. That's another option of adding on. But I think you guys hit that pretty well. So I thought it was a pretty cool case. See this a lot in the ICU. Eventually, we were able to resolve her underlying sepsis with the IV antibiotics. The blood cultures did come back and it was only E. coli, so we got rid of the Zosyn, kept her on the Rocephin. Eventually, the infection cleared. Her pressor requirements started coming down. We were able to get her off of the pressors, and she did quite well.
Very good. Very good.
Anybody have any questions or concerns before we wrap up this case study here?
Should you get arterial blood gas measurements, even though if she doesn't have any signs or symptoms of respiratory acidosis?
Yes, that's a great question. And I think that's a really, really good question, especially if the patient is getting so much fluids. If you're giving them a ton of fluids, you have to be somewhat leery about causing some pretty bad pulmonary edema and waterlogging those lungs and making it difficult to breathe. She didn't have any difficulty with that, so there was no indication or need to intubate the person. But yes, I think that's a great question. If I intubated them or if I saw that they were in respiratory distress, I could order an ABG. But unless I'm really having the patient intubated or they're in respiratory distress, I don't always order ABGs because I can get a decent amount of info off of my O2 sats and my BMP.
Gotcha. Very good.
Josh had a question?
Yeah, thanks, Zach. Interesting case. I just had a question about the SIRS criteria and diagnosing sepsis. In your experience, or from what you know, what's the utility of like saying someone has SIRS? Because like a lot of times everyone in Emerge SIRS criteria, it's pretty low threshold. So like I think of it as like is that your trigger to start antibiotics once you get cultures, or what do you do with that information?
So again, I look in the clinical scenario. I was thinking SIRS. Basically, when I see a tachycardia and a pretty profound hypotension and a fever, I'm already starting to get a little nervous. Those are kind of just like big telltale signs for me. And those would start to make me think, this is SIRS. If I get a white count and that comes back super elevated, then I'm definitely thinking SIRS. It's just, I think, how profound it is. If someone's a little hypotensive, and they are borderline febrile and they're not really that tachycardic and their white count really doesn't show like a left shift, stuff like that, then maybe I might lean saying, they do meet SIRS criteria, but are they really that sick that I need to start firing off UAs and blood cultures and get an entire sepsis protocol workup? I think it kind of just depends upon the severity of the vitals that you're kind of basing that off of and their white counts and just how sick the patient looks. For me, it's relatively simple because this patient looked crazy sick. Any other questions, guys?
Yeah, would you go with full heparin for her during the treatment, or would you not give her any?
So I I don't see a particular need for heparin, maybe subcutaneous heparin for like DVT, PE prophylaxis, but no, I don't see a particular need for her. She didn't have any signs of PEs, bowel ischemia, anything that would really, urge me to treat with heparin. I would be a little bit careful prescribing heparin to someone who I don't have an obvious source that I'm trying to treat, give them heparin for. If I'm giving them heparin, I need to have at least a real true indication of why I'm giving them heparin. They have to have some type of clot somewhere that I'm going to do that. Good question, though.